I believe the next speaker is Dr. Puneet Khanna. I've known him for quite some time now. A very lively person with a lot of enthusiasm and academic interest. Very lively person, and I hope the younger generation would learn from him in this current talk, which is very important: nutrition in ICU.
Good afternoon. Today we will be dealing with the topic nutrition in ICU. And myself, Dr. Puneet Khanna. I am from AIMS, New Delhi. So, what are the facts about why do we want to feed the ICU patients? 1/3 of the patients hospitalized in developed countries have some degrees of malnutrition at the time of admission. 1/3 of the patients admitted to the hospital without malnutrition will become malnourished during their hospital stay. Comorbidities that significantly increase the risk of readmission include weight loss, although the degree of weight loss is not defined, and iron deficiency, anemia. Patient loses around 2% of the muscle protein per day. Critically ill obese patients become malnourished. This is called as obesity paradox. Malnutrition in critically ill patients leads to poor wound healing, impaired immune function, and increased risk of sepsis. Muscle wasting that occurs due to protein catabolism leads to decreased ventilatory drive. Weakness complicates the separation from the ventilator. Weakness also complicating physiotherapy and mobilization. Cardiomyopathy occurs as a consequence of atrophy, mucosal atrophy, and diminished barrier function of the gut. It leads to increased duration of ICU stay and increased in-hospital mortality. This is an age-old diagram showing the total body composition, but you should focus on total body metabolic fuel. 23.3 grams of the circulating nutrients contribute to 113 kilocalories. 75 grams of hepatic glycogen contributes to 300 kilocalories. 150 gram of muscle glycogen contributes to 600 kilocalories. 6 kg protein has somewhere around 24,000 kilocalories. 15 kgs of fat has 141,000 kilocalories. Out of this, the circulating fuel consists of 20 grams of glucose contributing to 80 kilocalories, 3 grams of triglycerides, 0.3 grams of free fatty acids. In total storage, there is 165,900 kilocalories. However, in circulation, there is just 113 kilocalories. So what happens to the body as a rate of response in comparison to the starvation time? Glycogenolysis, glyconeogenesis, lipolysis, or ketogenesis as the duration of hours increase. To summarize, there is a post-absorptive phase. The CNS and many other tissues preferentially use glucose which is produced from glycogen breakdown. In gluconeogenic phase, protein catabolism is used to feed glucose to the CNS while other tissues feed on ketones and fat. In protein conservation phase, protein catabolism is decreased to minimum, fatty acids are used everywhere, and ketones instead of glucose to fuel the CNS. This is to summarize what happens in the critical illness course. Days 1 to 2, acute phase known as the early period, increased catabolism. Days 3 to 7, acute phase, late period, and then late phase of the rehabilitation or the chronic phase where anabolism might start. If we compare starvation versus stress hypermetabolism, points to compare are gluconeogenesis, which is more in hypermetabolism, proteolysis, which is more in hypermetabolism, protein synthesis, which is more in hypermetabolism, increased in urinary nitrogen, which is more in hypermetabolism, and increased ketone formation occurs during starvation. This is the major difference which occurs between starvation and stress hypermetabolism in a critically ill patient. So in a nutshell, acute or chronic malnutrition along with comorbid states has led to inadequate demand and need ratio, increases the nutritional risk. Stress-induced inflammation increases the catabolism and reduces the anabolism, which again leads to the nutritional risk, which leads to increased length of stay, increased ventilatory days, and increased morbidity and mortality in patients. So how to screen and how to assess? Screening to identify characteristics known to be associated with nutritional problems, to identify patients who are at risk of nutritional deficiencies and subsequent problems related to these deficiencies. Identify and subsequent problems related to deficiency. Assessment, process of collecting and assessing data about clinical conditions, diet, body composition, which includes biochemical data in order to diagnose patients with poor nutritional status. Problems with nutritional assessment in the ICU. Parameters have been devised, but how they are validated or invalidated. Weight or BMI has an invalidation due to edema, fluids, and diuretics. Anthropometrics, inter-observer variability. Albumin, pre-albumin. Acute phase of inflammation, infection, and injury might lead to decreased albumin. Nitrogen balance, drainage tubes, wounds, and renal failure. So ASPEN 2016 suggests not using traditional nutritional indicators or surrogate markers as they are not validated in critical care. So subjective global assessment status, what does it indicate? SGA, what are the criteria? Weight loss in previous 6 months, dietary intake, GI symptoms, functional capacity, disease type, subcutaneous fat, muscle mass, dependent edema, and ascites. So A consists of well-nourished, B moderately nourished, C severely nourished. You can go into the details. Nutrix score is a bedside score which is commonly used, but how easy is its bedside applicability? It consists of age, APPEC, SOFA, number of comorbidities, days from ICU hospital to admission, interleukin 6, and there is a table, Nutrix score. If interleukin 6 is available, 6 to 10 points consist of a high score, low score if it is 0 to 5, Nutrix score if IL-6 is not available, then 5 to 9 consists of a high score and 0 to 4 consists of a low score. NRS 2002, it is applicable bedside. It's a simple measure. BMI, has intake been reduced during the last week? Has there been a recent weight loss? Is the patient severely ill? Mild, moderate, severe, total score. It's a simple bedside scoring system. What is new in it? American Society of Parenteral and Enteral Nutrition has issued a clinical guidelines, the validity of body composition in assessment of clinical populations, fat-free mass, lean soft tissue, skeletal mass, fat mass, adipose tissue. This includes a simple bedside association which can be carried out. Then there are clinical guidelines for using DEXA or BIA in adult clinical populations. Dual energy X-ray absorptiometry is a valid method of assessing body composition in various clinical populations, but quality of evidence is really low. So what we see is ultrasound a valid method for assessing body composition of various clinical populations. Recommendations are weak and quality of evidence is low. Is bioelectrical impedance a valid method for assessing body composition? Again, the quality of evidence is low and recommendation is weak. So what we see is let it be DEXA, ultrasound or bioelectrical impedance. The quality of evidence is low grade and recommendations are very weak. So let's see what does ASPEN and Indian. So European Society, all ICU patients should have a nutritional risk assessment within 24 hours of admission or as soon as possible or feasible. ASPEN says assess the patients on admission to ICU for nutritional risk and calculate both energy and protein requirements to determine quality of nutritional therapy. Indian guidelines say all should undergo nutritional assessment. Monitoring of nutrition should be on an everyday basis. So which method to use? Indian, ASPEN or ISPEN? So ASPEN, based upon the expert consensus, we suggest determination of nutrition risk. Example, NRS 2002 or a Nutrix score be performed on all patients. High nutrition risk identifies those patients most likely to benefit from early enteral therapy. What does ASPEN says? We disagree with the American Society and categorize patient due to NRS or nutritional risk to define the nutritional image. A definite acute critical illness associated malnutrition still needs to be developed. So Europeans don't agree with Americans. So they have a threshold for severity of grading into mild, moderate and severe. This is European Society based upon weight loss, body mass index, muscle mass, and they have taken into consideration the etiology as well. So when do you start nutrition, early or late? You should try to start it within the first 48 hours of ICU stay. Why 48 hours important? Hypercatabolic state starts, decreased gut health, added insults of gut bacterial translocation and malnutrition. Delaying nutrition produces the risk of refeeding syndrome. What are the pros and cons of early nutrition? Advantages of early nutrition: maintain delivery of macro and micronutrients, defense of gut flora and intestinal mucosal integrity, prevents refeeding syndrome, treatment of any sort of underlying malnutrition. Enteral is safer than the parenteral nutrition. A disadvantage: poor tolerance, total body utilization may not be normal. No evidence that it prevents muscle catabolism. Hypercatabolic stress response is adaptive or working against, may be counterproductive. Together with stress response, hyperglycemia may result. So these are the pros and cons of early nutrition. What does the evidence say? Evidence is in support of early nutrition. No harm from early nutrition. Meta-analysis suggests that there is decreased risk of infectious complication, but only when non-ICU patients are included. There is a good evidence that trophic feeding is beneficial. Early nutrition need not to be targeted at a full goal rate. Evidence against early nutrition: none of the RCTs have demonstrated a mortality benefit. Many studies, as such, have demonstrated that hyperglycemia has a significant association with increased mortality in ICU. Guidelines. Guidelines are not guidelines. However, APPEC 2019 says if oral intake is not possible, early enteral nutrition within 48 hours should be initiated. APPEC says early enteral nutrition initiated within 24 to 48 hours in patients who is unable to maintain volitional intake. Indian guidelines: enteral nutrition should be started early, preferably within 24 to 48 hours. Now comes the Asia Pacific. Early nutrition therapy within 48 hours in critically ill patients, unless and until there are significant contraindications. Enteral versus parenteral. Theoretical benefits: enteral reduces the risk of SARS, preserves gut mucosa, maintains integrity of the gut mucosa, more balanced composition of amino acids, provide trace elements, and maintains secretory IgA producing immunocytes, or the GALT. Contraindications to NG tube placements: esophageal trauma, ischemic or damaged gut, obstructed gut, too fast transit time like infectious diarrhea. So what does the guidelines say? Oral diet shall be preferred over enteral or parenteral. If oral intake is not possible, then early enteral. In case of contraindications to oral, enteral, parenteral within 3 to 7 days. Avoid overfeeding. APPEC says use of enteral over parenteral. Indian says enteral should be considered over parenteral. Tube feeding to be considered even if 50 to 60% of the nutritional targets are not met adequately within 72 hours. So the crux is, if the gut works, use it. If you don't use it, you will lose it. Bowel sounds. The gastrointestinal myoelectric and clinical patterns of recovery after laparotomy. Bowel sounds do not indicate bowel function. It only indicates the passage of air. Normal myoelectrical activity returns to small intestine within 4 to 8 hours after surgery, whereas colonic recovery doesn't occur until 3 to 5 days. Colonic recovery hastens when stimulated by enteral feed. Fasting again prolongs the ileus. This is use of vasopressors and enteral nutrition. So various trials, what do they suggest? Eventually, APPEC says, based upon the expert consensus, we suggest in the setting of hemodynamic compromise or instability, enteral feed should be withheld. Surviving sepsis guidelines, we recommend against the administration of early parenteral nutrition. We suggest either trophic or hypocaloric feed to be started until early full enteral feed is started. APPEC says in patient with septic shock receiving vasopressors or inotropes, no evidence-based answer can be proposed. APPEC says enteral should be withheld. Surviving sepsis says against the early parenteral nutrition. They say we suggest either trophic or hypocaloric feed. APPEC says in septic shock receiving vasopressors or inotropes, no evidence-based answers can be proposed. Then comes the question of intermittent and bolus method of feeding in critical care. Guidelines say continuous rather than bolus enteral nutrition. According to European Society, American says for high-risk patients or if intolerant to bolus gastric enteral nutrition should be switched to continuous infusion. Indian guidelines says continuous formula feeding with pumps or gravity bags via fine bore 8 French to 12 French tubes. So we give a continuous rather than a bolus. Taking into consideration different routes of nutrition, gastric, duodenal or jejunal, access by NG, nasoduodenal tube or nasojejunal tube, indications, advantage, disadvantage. So what are the advantages of gastric? Large reservoir, normal gut function, cost effective. Disadvantage, increased incidence of reflux. Duodenum, reduced risk of aspirations. However, there is a disadvantage of GI intolerance, requires fluoroscopic or endoscopic placement, risk of displacement into stomach, unable to use tube aspirates to seat. Tolerance, no gastric acid present. Nasojejunal, it has a reduced risk of early feeding after trauma. What does the guideline say? Gastric access as a standard approach. European, post-pyloric feeding if gastric feeding is intolerance or high risk of aspiration. American, initiate enteral feed in the stomach. Indian, NG is the first route of choice. Asia Pacific, gastric feeding through nasal or oral gastric tubes unless contraindicated. So when everything is enteral, when to start parenteral? Any disorder in which enteral feeding is not an option. Short bowel syndrome, prolonged bowel rest, gastrointestinal fistula, bowel obstruction or ileus. Any disorder where enteral nutrition fails to meet the metabolic requirements of the organism. So when to initiate parenteral nutrition? When the patient is at risk of nutritional depletion. Low risk patients or well nourished, NRS 2002 says scores less than 3, start TPN after 7 days. High risk patients greater than 5, early TPN as soon as possible. Patient on enteral feeds, inadequate TPN more than 7 days have been passed. Patient on parenteral nutrition, undernourished, continuing on parenteral nutrition. Parenteral nutrition when? So, parenteral nutrition should not be started until all strategies to maximize enteral nutrition tolerance have been attempted. Aspen says exclusive parenteral nutrition to be withheld over the first 7 days following ICU admission. Indian, in case nutritional requirement is not met adequately, even after 7 days, use of parenteral nutrition may be considered. So, what is energy expenditure and how to define energy expenditure? Predictive equations, Harris-Benedict's, Frank Fields, Fuso or the Hinton-Johns, reverse Fick methods, PA catheter utilizes cardiac output, VO2 and DO2, neglects the expenditure of energy by the lungs, indirect calorimetry or the estimated 25 kilocalorie per kg per day. This is the so-called ACCP, American College of Physicians. So predictive equations are cheap, quick, requires no expertise, accurate for many circumstances and predicts requirement. Reverse Fick method, it is invasive, does not incorporate metabolic requirement of the lungs, inaccurate in severe pulmonary pathology like ARDS. Indirect calorimetry has the advantage, may be included in extreme obese, includes extremes of core temperature, extremes of age. Limitations, expensive. Assumption of all oxygen use is for oxidative substrate, complex procedure, measure of metabolic fuel composition not demanded. It is not associated with any clinical benefit. Inaccurate in high PEEPs and high FiO2s. Difficult to interpret if the ventilator settings keep on changing rapidly. So, what to use? Predictive equations. Are they really predictive? So, Harris-Benedict equation have to consider REE into activity factor, into disease factor, into the thermal factor. These factors have to be taken into consideration before they really predict. Indirect calorimetry using Weir equations and respiratory quotient. Indirect calorimetry has practical difficulties. The metabolic cart is expensive, cumbersome. It requires special training. Use in children is complicated. And it is very difficult to be implemented in context of ECMO and various new modalities. Pragmatic arguments against the routine use is consumption of metabolic substrates. It's powerless to predict requirement for them. And no mortality benefit had been obtained. Guideline says in mechanically ventilated patient, expenditure energy and energy expenditure should be determined by using indirect calorimetry. If calorimetry is not available, use VO2 from PAC or VCO2. Aspen, same thing, indirect calorimetry should be used to determine energy requirements when available. In the absence of IC, predative equation, or a simplistic weight-based equation, 25 to 30 kilocalorie per kg per day may be used to determine energy requirements. So are the critically ill really hungry? This will tell us about the concept of hypocaloric nutrition. Hypocaloric feeds purposefully deliver less non-protein nutrients that are required. Trophic feeds less than 500 kilocalorie per kg, maintaining an integrity of the GI tract rather than nutrition per se. Permissive underfeeding provides 40 to 60% of the calories required. Underfeeding intentionally provides less nutrition. Trophic feeding does not have a nutrition as a goal, instead focuses on maintaining the gut integrity. Hypocaloric nutrition and its rationale. No method is 100% accurate. Theoretically, immunological advantage to hypocaloric nutrition. Effect of 100% nutrition on muscle breakdown is unknown. The hypercatabolic response to critical illness is adaptive, and working against it may be counterproductive. So this is a simple chart of what happens during parenteral nutrition: hypercapnia, elevated liver function values, hepatic steatosis, blood increase in blood ammonia, hyperinsulinemia, hyperglycemia, intracellular shift of phosphorus, cardiac failure, neuromuscular dysfunction, and azotemia. Evidence. What is a full feed? 72%, 70 to 80% of the resting energy expenditure, maximum benefit, greater than 70, increased length of stay, greater than 100%, increased mortality. Normocaloric versus hypocaloric feed outcomes. Meta-analysis failed to demonstrate an outcome benefit. What does the guideline say? Isocaloric nutrition can be progressively implemented in the early phase of illness. If predictive equations are using hypocaloric nutrition, should be preferred. APPEC says in obese, enteral nutrition regimen should not exceed 65 to 70% of the target energy. If indirect calorimetry is unavailable, use the weight-based equation. Indian says intentional underfeeding can be restricted to specific indication. Obese patients can be subjected to underfeeding. Enteral formula and their categories: polymeric, oligomeric, disease-specific. The list is endless. The polymeric is commercial and blenderized. Oligomeric, semi-elemental, and for short bowel intolerance. We can go through the details. Guidelines. APPEC says to use a standard polymeric formula. Indian says standard polymeric formula. This is our standard our hospital feed protocol. What do we give in renal feed, what do we give in dialysis patients, and what do we give in a COPD patient. Proteins, according to APPEC, during critical illness, 1.3 gram per kg protein equivalents per day. APPEC, protein requirement 1 to 2. Indian, 1 to 2 gram per kg per day. Carbs and fat, APPEC, glucose, parenteral nutrition, or carbohydrate central nutrition should not exceed 5 milligram per kg per minute. Intravenous lipid should not exceed 1.5 gram lipids per kg per day. Indian calories should be in the range of 25 to 30 kilocalorie per kg per day. Immunonutrition, arginine, glutamine, omega-3 fatty acids, antioxidant, probiotics. Benefits: disease modulating nutrients, attenuate metabolic responses, prevent oxidative stress, favorably modulate immune response, probiotics to alter gut environment. Glutamine, potential benefits in critical illness, enhance heat shock proteins, decrease cytokine attenuation, and preservation of muscle mass. Guidelines. Except burn and trauma patients, additional enteral glutamine should not be administered. APPEC, supplemental enteral glutamine should not be added to an enteral nutrition. Glutamine is not recommended in critically ill patients with multiple organ failure. Redox trial, early provision of glutamine or antioxidant did not improve the clinical outcomes. Arginine pathway, fatty acids, guidelines. Enteral nutrition enriched with omega-3 fatty acids within nutritional doses can be administered. High doses of omega-3 fatty acids should not be given. APPEC fatty acids should not be used routinely. Indian guidelines, arginine containing immunomodulating formulations, supplements with standard enteral in TBI patients is recommended. Nutshell, you can go through the crux: parenteral nutrition, micronutrients, and antioxidants. APPEC should be provided daily with parenteral nutrition. APPEC is a combination antioxidant, vitamins, trace minerals, doses who require special nutritional therapy. Indian says micronutrients can be supplemented on blenderized feed and those on parenteral nutrition. Disease specific, Renal. Aspen says patient receiving frequent hemodialysis or CRRT receive an increased protein, 2.5 gram per kg per day. Respiratory, trophic or full nutrition, enteral nutrition is appropriate for patients with ARDS, ALI, except those who have a duration of mechanical ventilation greater than 72 hours. Indian guidelines says calorie dense enteral nutrition, small frequent feeds, a specialty high fat, low carb formulation is not recommended. Septic patients, enteral feeding as tolerated within first 48 hours of diagnosis. Avoid mandatory full caloric feeding. No special immunomodulation supplement. Supplementation with TPN if goals are not achieved within 1 week. Diabetics, continuous feeding should be preferred over bolus. Continuous feed help in achieving better glycemic controls. Type of feed, low GI and low GL. Glycemic index is an important parameter in regard to dysglycemic patients. Liver, standard enteral formulation should be used in ICU patient with CLD. Enteral nutrition preferred. A whole protein formula providing 35 to 40 kilocalorie per kg per day should be initiated. Neurotrauma, REE increases by 100 to 200%. Early enteral feeding with high protein polymeric diet. Buns, enteral first choice, proteins 1.5 to 2 gram per kg, early initiation of enteral nutrition. Obesity, metabolic disarrangements are more derangements. And insulin resistance, impaired glucose tolerance, increased fasciitis immobilization, decreased oxidation, accelerated protein degradation, increased resting metabolic rate of obesity. ASPEN recommends high protein, hypocaloric feeding. Oncology, consequences of weight loss, if it is 5%, it's a poor prognostic factor, increases toxicity of chemotherapy. Weight stabilization, omega-3 fatty acids. We'll skip this. TPN. TPN can be given peripherally or parentally. General consideration, adequate central venous access, dedicated lumen, 12 hourly reassessment, requires close liaising with the dietitian and pharmacy. These are the various variables and the dosages which you can go through, peripheral vein and central vein. Designing of a parental formula, prepare a parental nutrition as per prescription, convert requirement to the prescription, calculation of dairy requirements. Practical guidelines for prescribing parental nutrition, usually the bag is 2 liter, carbohydrate to fat ratio 70 to 30, protein 1.5 to 2 gram per kg per day. Okay, these are the calculations, how to calculate lipid, dextrose and protein. Pre-mixed bags, Cabiven, used commonly, 2 liters, provides the following data which is mentioned. Calculations with this pre-mixed water requirement per day, 30 to 35 ml per kg. Available bag will deliver 1600 by carbohydrate 800, lipid 800, protein 68 grams. These are the parental nutritional support beyond the gut feeling quality control study, which was carried out in a tertiary care center by Nagarajan Ramakrishnan. Monitor site of vascular access, fluid balance, blood sugars, LFTs and triglycerides. Complications can be catheter related, metabolic or immune dysfunctions. How to wean from a TPN. Wean as soon as you can start off with enteral feeding, start with lower dose, decrease the amount of energy with TPN. When provision of enteral exceeds, stop it. Watch for hypoglycemia and electrolyte. Troubleshooting, you have to be careful about refeeding and dumping syndrome. Prokinetics. Erythromycin is a first-line prokinetic by Aspen. Metoclopramide by Aspen. Indian says etaclopramide and erythromycin. Both can be used. Monitoring of tolerance and efficacy. Aspen 2016 says monitor it daily. NPO of the patient surrounding time diagnostic test procedure should be minimized. In case of high GRVs, continue feeding with reduced volumes. We'll pass on this. Diarrhea. Enteral nutrition should not be interrupted for diarrhea. As per Aspen, enteral nutrition should not be interrupted in the event of diarrhea as per Indian. Routine use of probiotics is not recommended in all ICU patients. These are the various factors which will tell us about what are the risk factors for diarrhea in enteral nutrition. How to prevent enteral nutrition related diarrhea. Refeeding syndrome, it's an important topic to be discussed. It's an anabolic reaction, potentially life-threatening condition associated with serum electrolyte shifts. Trigger is the switch from a catabolic to an anabolic state. Usually occurs first 3 days of starting nutritional support. High mortality, population, particularly older patients with HIV and critical illness. This is the flow chart. How does decreased blood flows, decreased circulating illness, then increased blood glucose, sudden increase of insulin leads to regeneration of tissues, abrupt decrease in pyruvate phosphate, and how does intracellular phosphate depletion leads to it? What are the systemic consequences of refeeding syndrome, cardiovascular, GI, renal, hematological, neurological, and immunological? These are the various risk factors associated with it. What are the nice diagnostic criteria? Either one of the following: unintentional weight loss, minimal or significant nutritional intake, lower concentration of plasma potassium, phosphate, or magnesium before feeding. These are the various flow charts which can tell you how to utilize it. This we will discuss. What is the patient nutritional status, well-nourished or severely malnourished, acute phase, acute late phase, recovery phase, 1 to 2 days, 3 to 7 days, greater than 7 days, and how to target nutrition in every. This is a protocol-based guidelines, patient admission, check for patient hemodynamic stable, if not stable, wait for stabilization, assess, calculate, then whether the patient enteral nutrition can be initiated, yes or no. If no, then initiate parenteral. Tube feeding, initiate enteral, start within 24 to 48 hours, monitor, start early, check for tolerance. These are the various flow charts which one can follow. Thank you. I think it was very elaborative, but the message has been conveyed.
Thank you, Dr. Khanna, for a very comprehensive, though nutrition appears to be a very simple subject, but the way I think you have elaborated the differences which are there between the ASPEN and the SPEN, I think students should appreciate it, that the topic is not easy, whether it is in terms of giving or following it up, or even the monitoring and in different disease entities. It's a very complicated subject, and even the experts so far are not on agreement how to deal with it. It's a very well, you have summarized very well for the students. I don't think anybody could have done it better. Very well done. Very well done. Very well.
Thank you, sir. Thanks a lot. Actually, it's a very elaborative topic, sir. I had tried to concise it, but it's very difficult to put it in all together.
It's simply not possible. I think you have, what you have done is you have pointed to the students the complexities, what the students have to see, in what point to start, how to evaluate indirect calorimetry, or in terms of the equations which are there. It's not possible to evaluate. How many centers can do it? It's just not possible to do it. Like in GI surgeries, students, others have a problem doing it. And you have highlighted all the complexities. It's been an eye-opener for them. That's what I can say. Thank you.
Thanks a lot. Thank you.
Thank you.
Thank you, sir. And thanks to the speakers for enlightening us on these topics. Beautifully presented, sir. Beautifully presented, and I'm sure it has immensely helped the students in their upcoming exams. Thank you so much, sir. I think it's very important. Like, guidelines are there, but then what to read out of them becomes really difficult. So just try to bring the zest out of it. Thank you.
Yeah.
Thank you.
Thank you, sir. Thank you so much, sir. Moving on with our next session. I would like to invite the chairperson for this session. I think there's some, just give us a second. We'll shortly resume the session.
Good evening.
Welcome back. So we'll resume with our next session, which is the last session for the day. I would like to invite the chairperson for this session, Dr. Anshu Gupta. Ma'am is working as Director Professor in the Department of Anesthesia at Lady Hardinge Medical College. And ma'am's area of special interests are pediatric anesthesia, obstetric anesthesia, and airway management, along with ultrasound-guided regional nerve blocks. We welcome you, ma'am. And I hand over the proceedings of the session to you.
Thank you, Dr. Nitin. I would say last but not the least, and although it has been, there have been exhaustive days and exhaustive day today also, but I would say that session is important. Our first speaker is Dr. Abhishek Sharma. He is Associate Consultant in